Good morning. Time now 8 o'clock in the morning in Tokyo, Tuesday, November 16, 2021. Welcome to another edition of the World Bank Group morning seminar organized by the World Bank Tokyo office. My name is Koichi Omori. I am Senior External Affairs Officer of the World Bank based in Tokyo. We organize so many interesting seminars virtually, introducing the latest report presented by the World Bank Group economists and specialists. This morning, we are introducing the latest edition of the Middle East and North Africa Economic Update, which was released on the October 7th. This is the final regional economic update of the October 2021 edition, as we are trying to cover all of the 6 regional reports in our morning seminar program. Connecting from Washington, we have 2 economists from the Office of the Chief Economist for the Middle East and North Africa of the World Bank. First, Rachel Yuting Fan, the economist and the team leader of the report. Rachel, good evening, good morning to you.
Good morning.
Great, thank you very much for joining. And then secondly, we have Ha Gwen, the senior economist, also from the Office of the Chief Economist for the Middle East and North Africa. Good morning, Ha. Good evening to you.
Good morning, Koichi, and good morning to everyone in Tokyo.
Great, thank you. 2 of them are now becoming the regular speaker in our program to present the latest edition of the Middle East and North Africa Economic Update. Thank you very much for joining. We'll listen to Rachel presenting the main report of main point of the report in the next 35-40 minutes. Then Ha will read the responding to the question that we received from our viewers. If you did not have an opportunity to send your question in advance, please do so even during the seminar using online form posted on the web page announcing this seminar, or you can certainly post your question on the chat section of the YouTube screen. I'll read your question asking the speaker to respond after the presentation. With that, I would like to invite Rachel to come in to start your presentation. Over to you.
Thank you so much, Koichi. Thank you for inviting us. It's a great honor for us to come here at each time of the year that for us to present our semi-annual flagship report to our colleagues in Tokyo. So let me share the screen first. Okay. So this report is produced under the leadership of our chief economist, Roberta Gatti, and under intellectual guidance from Daniel Letterman, the deputy chief economist. I'm also joined today, as you have introduced, by one of the lead authors of the report, Ha Gyuin. Thank you, Ha. And among our co-authors teams are also Ariane Hatife, Anya Saltman, Joseph Martin Sachs, and Christina Wood. I owe each and every one of them a big thank you for their extremely hard work in producing this report. So this report is called Overconfident: How Economic and Health Fault Lines Left the Middle East and North Africa Ill-Prepared to Face COVID. So the roadmap is to start with, we will introduce the GDP forecast for the region, which shows a tenuous and uneven economic recovery in 2021. Follow that, we will introduce long-term socio-economic trends that left MENA with overburdened public health systems, which we will talk from fiscal myopia associated with lack of economic reforms and epidemiological trends that left MENA with high death rates due to both communicable disease and non-communicable diseases. And we will also talk about high fertility rates that create the illusion of a healthy population. Follow that, we will introduce how we measured ill-prepared and overconfident health system prior to COVID in the MENA region, and how overwhelmed the health system shows during COVID-19. And we will finish by introducing data transparency and policy recommendations. So to start with, the region's GDP, according to latest World Bank forecast, has contracted by 3.8% in 2020, and we expect it to grow by 2.8% in 2021. We show the development in GDP in terms of GDP levels, as you can see in the solid black line on the left-hand side chart. Built upon the negative GDP growth of 2020 for MENA, even with a positive growth of 2.8%, MENA would still be below its 2019 GDP level by 1.1 percentage points. As you can see that the black solid line starts at 1 in 2019 and couldn't rebound to the horizontal line of 1 as of 2021. As a rough approximate of the economic loss from the pandemic, we compare the latest forecast, namely World Bank forecast October 2021, with the latest forecast vintage conducted before the pandemic, which is World Bank forecast October 2019, during which we have forecasted consecutive positive growth more than 2% for both years 2020 and 2021. So based on that forecast, we depicted what the GDP levels would have been in a no pandemic scenario in the dotted black line in the left-hand side chart. As you can see, this dotted black line starts in 1 in 2019 and climbed above 1.05 at 2021, indicating a more than 5% increase in GDP levels compared to 2019. So the difference between the GDP level in 2021 in the pandemic scenario, which is the solid line, and in the no pandemic scenario, which is in the dotted line, could be our approximate of the economic loss due to the pandemic. We have calculated it's around 7% of the 2019 GDP, which is almost 200 billion USD. If we decompose MENA region by country groups, we can depict the GDP growth for each group on chart on right-hand side. As you can see, red lines represent GCC countries, orange lines represent developing oil exporters, and blue lines represent developing oil importers. GDP growth for 2021 is forecasted at 2.6% for GCC, 3.2% for developing oil exporters, and 2.8% for oil importing countries. The distance between the dotted lines and solid lines again indicate that all three groups will suffer economic loss compared to the GDP level that they could have reached in a no-pandemic world. That being said, what we care most is the level of GDP per capita compared to GDP. GDP per capita is arguably a more precise measure of the region's standard of living. Since the population in the region also grows by 1.6% in 2020 and 1.7% in 2021, the growth in GDP per capita is smaller than that for GDP. So based on the most recent forecast, the region's GDP per capita is forecasted to grow by a mild 1.1% this year, after a contraction of 5.4% last year. As you can see from the solid dark line on the left-hand side chart, compared to 2019 income level, which is shown as the horizontal line of 1, the region's income level in 2021 is still 4.3% below. And similar as before, we depicted the forecasted GDP per capita level in no pandemic scenario in the dotted line on the left-hand side chart, which is based on forecast of GDP per capita conducted in October 2019, the latest forecast before the pandemic. Compare the end of the solid line and the end of the dotted line, we see the economic consequences to per capita income level, which amounts to around 7%, which will be reflected in an increase of the poverty rate. If we zoom into the three country groups, the level of GDP per capita is depicted in the chart on the right-hand side. For year 2021, the growth in GDP per capita is forecast at 0.3% for the GCC, 1.6% for developing oil exporters, and 1.2% for oil importing countries. None of the three country groups would recover to income level back in 2019, which is shown as the horizontal line of 1. And if we compare the distance between the dotted lines and the solid lines with matching colors, we can see that the cost to the income level is 8 percentage points for GCC, 3% for developing oil exporters, and almost 9 percentage points for developing oil importing countries. Across the countries, the growth rate for GDP per capita in 2021 will be uneven, ranging from negative 9.10% in Lebanon, which is in a deep recession, to 4.0% in Morocco, and 13 out of 16 countries covered in the macroeconomic forecasts in the region will have lower standards of living in 2021 than their pre-COVID levels 2 years ago. So during this unprecedented pandemic, we believe that testing capacity is a crucial part of the health surveillance that is essential to disease prevention and response, at least at the beginning of the pandemic. This figure shows the partial correlation between COVID positivity rates and the macroeconomic costs of the pandemic in 2020, which is proxied by the difference between pre-pandemic growth forecast and the current estimates of GDP growth rates for 2020. And the econometric estimates suggest that a 1% reduction in a country's test positivity rate is associated with a 0.08% deterioration in the expected growth rate in 2020. So let's take a look at MENA before pandemic happens. Lackluster economic reforms in the decade prior to COVID have left MENA a legacy of large public sectors and high public debt that effectively crowd out investments in social services such as public health. This is what this report calls the syndrome of fiscal myopia. In the left-hand side chart, you can see that despite the need to transition to market economies, the public sector's role instead expanded after 2011. To document the region's truncated economic transition, this report uses government expenditure as a share of total GDP as the proxy indicator to represent the size of the public sector's economic footprint. And the chart shows that MENA is the only one of the world's regions where government expenditures as a share of GDP grew substantially from 2009 to 2019. The more than 2% growth in MENA contrasts with a decline in many other regions. The right-hand side chart shows that in MENA, spending on health is overshadowed by large public sector wage bills. For all MENA countries with available data, the ratios of government health expenditure to public wage expenditure are below those of other countries with similar income. MENA countries, as shown in red dots, on average in 2019, had low public expenditures in health relative to expenditures in public employment. In addition, what matters is how well money is spent. But data show that fewer resources are devoted to preventive health and building a health system. Data for 65 countries, including 3 in MENA, Egypt, Tunisia, and Jordan, as shown on the chart on the left-hand side, had shown that preventive health care expenditure as a share of general government expenditure in these 3 MENA countries is lower than in the other income peers in the sample. For example, a country with the same income per capita as Tunisia is expected to spend about 0.83% of general government expenditure in 2018 on preventive health care, but Tunisia only spent 0.55%. On the right-hand side, you can see that spending is also lower for government administrative healthcare expenditure as a percent of general government expenditure, but to a lesser extent. Tunisia is right on the fitted line. The lack of budget flexibility prevents governments from assuming the costs of providing healthcare and shifts health spending to patients who must pay out-of-pockets. Out-of-pocket spending, what we call OOPS, accounts for a major portion of health spending in many middle-income and low-income MENA countries. As you can see in the chart, the share of out-of-pocket expenditure in total health spending is 60% in Egypt and 80% in Yemen, but only 6% in Oman, reflecting how financial risks is shifted to families in low-income countries and middle-income countries, as well as the advantages of the well-funded health system in richer countries. Demographically, before the pandemic happens, all GCC countries except for UAE and more than half of non-GCC countries had higher fertility rates than their income peers in 2019, as you can see in the chart. Data from UN World Population Prospects show that the fertility rate dynamics in many countries of the region changed from years of continued declines to a sudden increase in the late 2000s and early 2010s. Indeed, in the aftermath of the Arab Spring, most MENA countries had a typically high fertility rate for their levels of development as of 2009, or experienced unusual increases in fertility rates between 2009 and 2019, and yielding truncated demographic transitions. Rising or typically high fertility rates generated a youth population bulge that masked the region's comparatively poor health, which you will see in the next chart. The rising in number of youth in MENA during the 10 years before the pandemic created an statistical illusion of a healthy population. MENA's deaths from NCDs per 100,000 people are shown in two charts here. The left-hand side chart plots NCD deaths per 100,000 people against GDP per capita in 2009. And the right-hand side chart relates NCD deaths per 100,000 to the initial income level in 2009, but after age standardization, which assumes that age groups have the same representation in all countries of the world. In the chart on the left-hand side, it appears that MENA countries had fewer deaths from NCDs than did their peers in 2019. But it is a statistical illusion due entirely to the age composition effect. In the right-hand side chart, after adjusting for age of the population, almost all MENA countries have a greater than expected number of deaths from NCDs. This is worrisome because it implies that the comorbidities and lifestyle factors that underlie NCD deaths are high in MENA for all age groups relative to societies at similar levels of development. Because the strongest comorbidities for COVID-19 infections are rooted in weight and metabolic health, for example, diabetes, heart disease, insulin resistance, the fact that NCDs are occurring more than they should among the younger population in MENA is concerning. This truncated epidemiological transitions, as well as demographic transition and economic transition, are largely a result of weak public health systems. To further explore MENA countries' pre-COVID-19 pandemic preparedness, the analysis in this report relies on data from two existing indices of health security robustness. The first one is the Global Health Security Index, GHSI, which is conducted by objective external evaluators. And the second one relies on a self-reported assessment by individual countries. It's called the State Parties Self-Assessment Annual Reporting Tool, SPAR. So to construct a resilience framework for MENA countries, the GHSI data and SPAR data are adapted to provide a metric of MENA's public health system's ability to absorb a shock prior to 2020. The four pillars derived from those indicators are surveillance capacities, information sharing, health system capacity, and regular planning and readiness exercises. Each country's scores are then econometrically benchmarked against other countries at similar levels of development. So numbers that you see in panel A show deviations from predicted values normalized by standard deviations using GHSI data. And the cells in this table are color-coded to show deviations within the 33% confidence interval of the predicted values in yellow, above the 33% confidence interval in green, and below 33% confidence interval in red. We do the same methodology to SPAR number. That's what you can see in panel B. Table in panel B show color-coded standard deviations from predictions using SPAR data. Standard deviations in SPAR for each pillar, each country from panel B subtract its corresponding standard deviations in GHSI from panel A would result in overconfidence index that we calculated and shown in panel C. So cells in panel C are color-coded redder for a higher overconfidence index and greener for a lower or more negative confidence index. And the result is that, as you can see in panel A, of the 19 MENA countries across 4 areas of preparedness, MENA countries' GHSI data consistently underperformed their income level benchmarks. Every country, except Jordan, has at least one pillar in which it underperformed peers, and only Jordan and Morocco have 3 pillars in which they outperformed peers. And in panel B, by contrast, only 6 of 15 countries gave themselves low enough ratings to show that they were underperforming. Egypt and Morocco rate themselves as outperforming their peers in all 4 pillars. The UAE, Algeria, Tunisia, and Iraq believe that they would outperform their peers in 3 of the 4 pillars. And in panel C, the table also documents the region's tendency toward overconfidence by showing the differences between the 2 tables. And in 41 out of the 60 performance categories, 4 for each of the 15 countries, MENA countries displayed overconfidence in 41 of them. So COVID-19 is more like a stress test to this health system. Admittedly, the stress test triggered by the pandemic has not yet produced firm conclusions on the resilience of health system. However, it seems clear that the limited resilience on the health system, the limited resilience of the healthcare workforce, and the supply of medical products and technologies have already caused critical bottlenecks. This table is produced according to the WHO Pulse survey. The Pulse survey found that 53% of the WHO Eastern Mediterranean Regional Office countries reported disruptions in the delivery of healthcare service because there are not enough staff available. This could be due to healthcare workers reassigned to care for COVID-19 patients, or the large number of infections among healthcare workers, among other reasons. But the result we see is that the health system in MENA is overwhelmed during COVID-19. But how to measure this overwhelmed health system? Except for the official reports, one widely considered objective indicator of deaths caused by COVID-19 is the excess mortality. The number of deaths from all causes above the expected number of deaths during a specific period. All-cause mortality includes reported COVID deaths, unknown or unreported COVID deaths, and other deaths, whether from disease, accidents, or something else. These other deaths might have been related to the pandemic, for example, a suicide spawned by isolation, or a condition inadequately treated just because health resources were shifted to COVID-19. The excess mortality measure has long been used to estimate the death toll of pandemics and other extreme events. This figure on the left-hand side shows rising excess mortality in selected MENA countries. Most, if not all, of the excess mortality is believed to be the result of the pandemic. And how much is this measure of excess mortality compared to countries' reported COVID death? Karlinski and Kobach 2021, in this paper, they use excess mortality as a proxy of death from COVID, particularly for countries whose official data of COVID is incomplete. So they calculated the undercount ratio on the right, as you can see on the right-hand side. The undercount ratio relates excess mortality to reported COVID-19 deaths. A high undercount ratio implies that unknown and unreported COVID deaths and other deaths were missed. Our table presents the undercount ratios for 6 MENA countries with available data. The undercount ratios for most MENA countries were below 3, except for Egypt. Egypt has one of the world's highest excess morbidity rates relative to official COVID-19 cases in the world. The undercount ratio for Egypt is 13.1. The large number of deaths, the even larger number of serious infections, and the disruptions to the economy, healthcare system, and private lives presented public leaders with an emergency they had to respond to and formulate policy for. Both the overconfident assessment of health system preparedness and the undercounted COVID deaths has revealed lack of data transparency in MENA for public health. Overhauling data systems as part of health system reforms is an urgent area for action for the MENA region. In high-quality, reliable, and timely data that can be linked across databases and across time is needed to generate tremendous benefits for health systems in general and for a country's pandemic response in particular. Building resilient and effective health systems in MENA is a comprehensive task, but what is common across MENA countries is the lack of reliable, high-quality digital data to inform transparent and accountable decision-making. So we try to document the difficulty of finding and accessing commonly used indicators to assess pandemic response of countries in the region. We researched the availability of 9 indicators related to COVID-19 across 18 MENA countries. And the selected indicators provide basic information about key aspects of public health and about the conditions facing frontline health workers during the pandemic. So this figure shows the availability of 9 indicators by country. And this figure shows availability across countries for each indicator. The data were found to be publicly available only about half of the time in MENA. And sometimes data were collected but not publicly available. In many cases, it was not possible to be certain whether the data was or was not available. This shows that even if data is collected, it is often difficult to find and access. We learned that MENA countries were overconfident about preparedness of their public health system. And we also show that prior to the pandemic, 3 long-term trends undermined growth and made MENA ill-prepared for health system shocks. We show it by going through economic transitions, demographic transitions, and epidemiological transitions. Follow that, we show that COVID has shown the weakness and ill-preparedness of the region's health systems, and COVID has illustrated the relevance and benefits of data systems. So the policy implications are we should improve availability and use of data, which will facilitate appropriate planning and preparedness for regular and emergency healthcare. Thank you very much.
Thank you very much, Rachel, for your presentation on the main point of the latest edition of the MENA Economic Update. We received several questions from our viewers, and let me start reading the three questions that we received from the anonymous participant. Thank you very much for sending those questions always. Let me start the first one. Could you clarify whether your analysis includes the data of non-nationals such as immigrants and refugees? And how do you analyze the difference among the different nationalities? I'm asking this because civil registration is mentioned on the birth and death indicators of the figures, which is titled as the public health data in MENA lacking on the slide number 13. So perhaps if you have any response or comment, Rachel, please respond. Thank you very much.
Thank you, Koji. So first of all, let me also thank you, Koji, and the audience for the interest in our report. It's our pleasure, it's our honor, in fact, to be here and talk about our report with you. And here we also have Christina Woods, senior economist in our office, who is here with us. So Christina and Rachel, feel free to come in. If you feel anything you would add. So let me answer the first question. So the first question is on whether we include non-nationals such as immigrants and refugees. So the answer is depends. In different analysis of the reports, we include refugees and immigrants, such as when we think about population. So when we think population, we include both refugees and immigrations. But when it comes to civil registrations, I think by construction, by definition, it only includes nationals. Specifically, talking about the figure at slide 13, what we did is we survey World Bank's health experts in each MENA countries, and they come back to us with their assessment of data. For example, they tell us whether the country collected or published data on births, on deaths, and on, say, average hospital occupancy rate. So, for example, if you look at cumulative hospitalization due to COVID-19, it should include hospitalizations for immigrants and refugees. So I stop here. Thank you.
Thank you very much for your response. And then I would like to welcome Kristalina Uz to be part of discussion. Thank you for your time to join us. Let me read the second question from the same the person. The question is this: out-of-pocket spending ratio of non-GCCs are high according to the figure of out-of-pocket spending in many MENA countries on the slide number 6. Could you disaggregate the content of out-of-pocket in terms of where they are coming from? How much does external debt ratio share going among them? So this is the second question. And perhaps let me read the third question altogether, so you can respond comprehensively. Third question is this: what do you recommend to improve the situation where non-GCC countries rely on out-of-pocket spending while facing with various health challenges, including not only communicable but also non-communicable diseases? So these are the two questions, and I'd like to ask her or others to come in to respond. Thank you very much.
Thank you, Koji. So to answer the first question, so the first question is whether out-of-pocket spendings can we discourage the content? So first of all, out-of-pocket spending is spending from households, right? So when a household member go to a medical center, how much is paid from the pockets, and that is the source of the out-of-pocket spending is basically households, and that's the understanding of out-of-pocket spending. So it's we cannot disaggregate any further, and obviously it should not include external debts among out-of-pocket spending, because by construction it's from the pocket of households. And generally, high out-of-pocket spendings carries a lot of disadvantages. First of all, it discourages people for their healthcare services, right? Because if you have to pay large out-of-pocket expense for your doctor visits, you can try to visit the doctors as few as you could because of the high pocket spending. So the idea is that the government should invest more in health spending, so that we could bring out-of-pocket spending to as low as they can, right? The situation in the non-GC countries show that, as Rachel showed, that these countries have higher out-of-pocket spending. It can reflect of, number one is the underfunded public health system, and this is the main finding of our report, and Rachel have discussed them very well in the presentation, that many MENA countries have low public health expenditure compared to public wage bill. And in addition, for a few countries that we have data, Jordan, Egypt, and Morocco, these countries also spend lower share of their expenditure, of their government expenditures on preventive healthcare and building a healthcare system. So all of that give us the picture that these countries was underspending on public health system. And and I think the first recommendation from our report is for a country to spend more on public health system, and also as the graph shows, we just don't have a lot of data, and countries also don't have a lot of data to have a good picture of what's going on. So the second recommendation is to to improve data transparency, and if we can if we're happy to go more to data transparency if needed. So that's my answer to the second question. Rachel and Christina, feel free to come in if you have anything to add.
This is very comprehensive. I don't have anything to add. Thank you.
Okay, great. Thank you. Let me read the next question. A question from Sasaki-san. Thank you for your question. How would the World Bank see and help the MENA government facing with the physical space challenges, particularly in non-GCC countries? Lack of reform, lack of data, lack of preparedness in health systems. And where should we focus and start with? It seems capacity building seems the key when looking at the chart on the overconfidence on the slide number 9. So Rachel, Christine, if you have any responses, please. Thank you.
Thank you, Koji. I think this is a fantastic question. It speaks to the challenge of the region. And as you follow our previous reports, we talk about the regions as being characterized as having chronic low growth, very large external imbalances in a sense that have large current account deficits, and also have large fiscal account deficits. And the technology development in the oil sector is putting a ceiling on the oil price, which will pose serious challenges for the oil exporters of the region, but also the oil importers of the region because of the interconnectedness in terms of FDI and remittances. And the energy transitions will not make things better for the MENA countries because of the global efforts to reduce fossil fuel. So that's an overview of the regions, and it's a very complicated issue, and the region, as laid out in our report, has faced economic, demographic, and also epidemiological challenges. So for our report, we focus on our recommendations on data transparency, and I think this is a good opportunity for me to go into data transparency a bit more. Data transparency is not only an issue for health, as emphasized in the report, but also a challenge for many other issues in MENA, right? So with regards to health, weak data transparency and data system contributed to the overconfident assessment of the system, of the health system. So as you can see, the health system in MENA was not only ill prepared, but also overconfident, and I think a big part of that is due to the lack of data, even to the authorities. So you know, obviously, underlying long-term trends such as the economic, demographic, and epidemiological trends generated, you know, huge challenges for policymakers to address. But I think the first thing one thing we can look at is to have a better data, because having access to the right information at the right time can help inform the policymakers' decisions, not only on health but also on other issues. So you know, restricting to the health issue of our report going forward, I think a key recommendation is that MENA public health system can benefit from an overhaul of data system as a part of the health system reforms, and to encourage a culture of openness and data use to better inform policy decisions. So therefore, increasing investment in data systems and increase other priorities of healthcare, you know, will be vital for the MENA health system. Thank you, Koji.
Thank you very much for your responses. We received the question from Professor Yoshino of Keio University during the presentation. So let me read his question. Private sector will operate public health care sector much more efficiently compared to the public sector. However, if all the health cares were run by private sector, poor families cannot receive sufficient health care. What do you think the best combination of the private and public sectors in healthcare sector? So if you have any responses, or Rachel or Christina, please. Thank you.
So Rachel and Christina, if I may I come in first to answer an interesting question from Professor Yoshino, sorry, and of course feel free to come in. I think this is also an interesting question, and to clarify, our report is not against the private healthcare. I think private hospitals play a very important role, you know, as we see in many advanced countries, but also in developing countries where resources from the government are limited. Having said that, there are important roles of the public health system can play that cannot be substituted by the private healthcare system, right? So we can think of preventative healthcare, right? We think of data collection, or the public uses of healthcare that cannot be replaced by private hospitals, because that's not simply their role. So I think emphasizing the important role of public health, such as preventive healthcare, data collections, monitoring, surveillance systems, those are the role of a strong public health system that cannot be replaced by private hospitals. So I stop here, and I let Christina and Rachel come in as needed.
Thank you, Han. This is almost exactly what I had in mind. So even in MENA, there are countries that has a very strong private health systems. But when it comes to the pandemic, it is more important that these are these private health providers cooperating effectively? Are they, for example, in terms of vaccination, in terms of reporting cases, especially in terms of tracing and tracing cases? This is where public sector healthcare comes into place and cannot be replaced. In the best ideal world, it would be great if the public providers and private providers can cooperate in a harmonized system that can provide the best healthcare to their residents. Thank you. I'll stop here.
Thank you very much for your responses. Let me read that question that we just received from Mr. Kiyoshi Kodera. Thank you for your question, Kodera-san. This is very timely analysis. So far, did the bank rapid response operation, fiscal support in particular, to the MENA's COVID-19 crisis include more health spending as conditionality? So this is a question. If you have any responses, or Rachel, please. Thank you.
Thank you, Koji, and thank you, Kiyoshi. So I think we should defer our answer on conditionality, because we need to check with our operational knowledge colleagues before we get back to you. So this is one promise that we can do that. We will do that. But having said that, I would like to emphasize that that much of the World Bank emergency response to COVID-19 is precisely on healthcare related to the pandemic, such as screening, testing, training, and assists the healthcare system not only in the MENA regions but around the world to build up that capacity to cope with the COVID-19 pandemic. And let me give you one example in Jordan. So from the materials that we've got before today's talk, in Jordan, the banks committed about $20 million to prevent, detect, and respond COVID-19 and strengthen the national health system. And in June, the bank committed another $63 million for the procurement and distribution of COVID-19 vaccines for Jordan. So from the best of our knowledge, most of the bank's emergency response is precisely on expanding healthcare and COVID responses for the MENA region.
Great. Thank you very much for your responses. You efficiently responded to the question that we received from our viewers. So I would like to ask Rachel and Ha to make the very final remarks, and then we'll wrap up our seminar. So Rachel and Ha, please.
Let me just take this opportunity to thank you again for inviting us. It's a great honor to have this opportunity to share our report with the colleagues in Tokyo. Very much appreciated. Thank you.
Same from me as well. So just want to add our thankfulness to Koji and the team and everyone from Tokyo. And thanks again for your interest in the report, and have a good evening. Have a good morning.
Great, thank you. We had a pleasure of having Rachel Yutin Fan and Ha Gwen from the Office of the Chief Economist for Middle East and North Africa. Also, Christina Wood from the same office joined virtually in the discussion. So thank you very much, all of you, for your time. Really appreciate it. Thank you. Great. We have interesting online seminars coming up. On December 1st, we are focusing on India, featuring our country director for India joining from Delhi virtually to our seminar. And on December the 3rd, we will be featuring the new report titled "At Your Service." So please stay tuned. Check our website for the latest announcement of those seminars. We post the formal announcement when we are ready in several days. So please check our website. So with that, I would like to once again thank everyone for watching our seminar. Stay safe, stay healthy. See you next time. Thank you very much.